Hello, everybody. My name is Stephanie Niemeyer. I'm a pediatric clinical pharmacist at St. Joseph's Children's Hospital, and today I'll be giving you the lecture on gastroesophageal reflux disease. On this slide, I have my email address listed, so please feel free to email me with any questions you have about the lecture or about gastroesophageal reflux disease in general. Our objectives today are first to understand the difference between gastroesophageal reflux and gastroesophageal reflux disease, so what turns it from a normal process into a disease that needs treatment, to be able to explain the pathophysiology and common causes of gastroesophageal reflux disease, and specifically within the pediatric population, to be able to match various signs and symptoms of GERD with various pediatric populations, so knowing how an infant might present with GERD versus how a teenager would present. By the end, you should be able to recommend treatment options based on a patient's symptoms, their cause of the reflux, and then considering various pediatric specific dosage forms and dosing. And then finally, to be able to create a treatment plan for an infant, child, and adolescent, so the three basic age groups of our pediatric population, and be sure to include lifestyle interventions and then medication management if necessary. Just an outline of how the lecture will flow today. First, we'll start with definitions, then we'll move to the epidemiology, so how many pediatric patients are affected by this disease. We'll talk about the pathophysiology and then long-term sequelae, so what happens if these patients go undertreated or not treated. The various signs and symptoms, focusing on the different age groups of the pediatric population, the risk factors for developing this disease, how a physician will diagnose it, and then we'll finish up with the treatment. And I would like you to focus, of course, on the medication section, as that's the most important for us pharmacists. Starting off with a couple simple definitions. The first one is regurgitation. This is the layman's term spitting up. So I think of it as most common in infants. It's just an effortless, non-projectile passage of gastric contents into the pharynx or the mouth. Sometimes they're expelled out of the mouth, but not always. It occurs daily in 50% of our infants under 3 months, so it's very common in our young infant population. And a lot of times parents think that spitting up is gastroesophageal reflux disease, when that's in fact not true. It will resolve spontaneously by 12 to 14 months of age, so this is a very normal process, especially in our young infants. Rumination is similar to regurgitation, except it is when the food comes up into the mouth, there's subsequent mastication or chewing, and then re-swallowing. So this is also a normal process. Gastroesophageal reflux is a little bit different than rumination and regurgitation because the gastric contents just come up into the esophagus. So they don't have to come up into the pharynx or the mouth, and there it does not have to be vomiting, but sometimes there is. So gastroesophageal reflux basically just means that stomach content has come up into the esophagus, and whether it goes farther turns it into regurgitation if it enters the pharynx or the mouth. This occurs in healthy infants as well. Children, adults, everybody, several times per day. A lot of times we don't even know that this is occurring. Usually not associated with any symptoms, lasts less than 3 minutes. Usually it occurs right after we eat a meal. This is a very normal process, but what turns it into gastroesophageal reflux disease is when the passage of the contents causes troublesome symptoms or complications to where the patient will seek treatment. Epidemiology of GERD in the pediatric population is not very well studied. We're not really sure exactly how many patients are affected by this. It's very largely overdiagnosed in the infant population, as a lot of parents will confuse normal regurgitation with having gastroesophageal reflux disease. So half of infants aged 0 to 3 months will have at least one episode of regurgitation per day, and 20% of their caretakers will seek medical attention for this normal behavior. Episodes of regurgitation tend to peak at 6 months of life, and then, as I said on the previous slide, it will spontaneously resolve by 12 to 14 months of life. They did find in a survey that adolescents report more reflux symptoms than their parents are aware of. So this suggests that maybe the adolescents are underdiagnosed, whereas the infants are overdiagnosed. There's about 1 in 4 North American adults that have gastroesophageal reflux disease. So this is a disease that will occur in the pediatric population and will continue on into adulthood. However, it is also common for an adult to acquire gastroesophageal reflux disease, and we believe that obesity is a contributing factor to that. The pathophysiology of gastroesophageal reflux disease is depicted in this picture. I like the one that is pulled out in the circle over there on the right-hand side of the screen. This shows the gastric contents coming back up into the esophagus. And for this circular picture, it is the reason of the lower esophageal sphincter being too weak. So it doesn't close off the bottom of the esophagus well enough, and it allows the gastric contents to come up into the esophagus. So this is a cause of gastroesophageal reflux disease in adults and pediatric patients. This can occur even more commonly in patients that might have some type of neurologic deficit to where their lower esophageal sphincter is weak or doesn't close. It doesn't close all the way. This picture depicts a more complete explanation of how GERD can be caused in our pediatric population. So starting at the top of the picture, we have decreased salivation as well as impaired esophageal acid clearance and impaired tissue resistance. So all of these it weakens the esophagus's normal protective barriers against the stomach acid. So when the stomach acid does reflux into the esophagus, if a patient has impaired resistance against this acid, then it's more likely to turn into gastroesophageal reflux disease. So the other things on this slide are also reasons that normal reflux could become reflux disease. If they have decreased resting tone of the lower esophageal sphincter and delayed gastric emptying time. So the longer those contents are in the stomach, the more opportunity they have to reflux up into the esophagus. So this could cause more reflux events per day, leading to troublesome symptoms for the patient. Long-term sequelae of these patients that have gastroesophageal reflux disease who are underdiagnosed or not appropriately treated are listed on this slide. So the first one is a hiatal hernia, and this is when the top portion of the stomach comes up above the diaphragm. This is troublesome because it does increase the severity of the GERD. So the size of your hiatal hernia is directly correlated to your severity of gastroesophageal reflux disease. And this can occur when erosive esophagitis has gone on for a prolonged period of time. So erosive esophagitis is when the gastric contents come up into the esophagus and cause erosion and inflammation. And with this erosive esophagitis comes esophageal shortening. So as the esophagus gets shorter, it pulls the top portion of the stomach up with it, and when it pops up above the diaphragm is when you get a hiatal hernia. The next bullet is Barrett's esophagus, and this is a very alarming adverse outcome that can come from prolonged gastroesophageal reflux disease. It's when the normal cells of the esophagus are replaced with cells that are more similar to our small intestinal cells, so they don't function like the normal esophageal epithelial cells, and they turn into precursors for esophageal adenocarcinoma. So Barrett's esophagus is a very serious condition that can lead to cancer. The last bullet on this slide is just shows how patients with gastroesophageal reflux disease are more likely to have these comorbidities. We're not really sure if the disease itself is what causes these morbidities like pneumonia and asthma, or if they just are simply a random correlation, or if it's our treatment that's leading to these comorbidities. But either way, the patients that suffer from gastroesophageal reflux disease are also more likely to suffer from these other diseases listed on the slide. The signs and symptoms of gastroesophageal reflux disease do vary a lot based on the patient's developmental stage. So I started out listing the ones that we would see more often in an infant, and I kind of gradually listed them as we would see them in an older patient. So the first one is feeding intolerance and refusal. So it's very unlikely that we would see an adult come in complaining of refusing to eat because he has gastroesophageal reflux disease. We would see this more in an infant that has no other way to express to us that eating makes them uncomfortable, or that it hurts to eat, or that they're having heartburn. We also see failure to thrive and weight loss because of the feeding refusal in these young patients. We'll see excessive vomiting and regurgitation that can cause erosion of the esophagus. The patient might also be inconsolable or extremely irritable, which is difficult for the patients of these young infants, the parents of these young infants. We'll also see very commonly acute life-threatening episode, and this is basically when a patient all of a sudden goes limp. They might stop breathing, they might turn blue. We're not really sure exactly what causes these because the parent will bring the infant in and just say things like they stopped breathing or they turned blue. So when a patient comes in is admitted to the hospital for an episode like this, they will get a whole workup for seizure disorders, blood glucose regulation, and then gastroesophageal reflux disease is one of the things that can cause a patient to have an event like this. Apnea spells, they can also be hard to differentiate from those ALTs or acute life-threatening episodes. And then on the right side of the column, you'll see things that we'll see in older patients like hoarseness, the ones that can talk, use their voice, and dental erosion, the ones that are obviously old enough to have teeth. So you'll see a complete list of signs and symptoms in the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition Guidelines on page 505, and that's one of your supplemental readings. So they also talk about the various developmental stages and specifically the signs and symptoms. This is just a repeat slide for all you visual learners. It's a table from the other supplemental reading. It's the Guidance for Pediatrician by Lightdale, the other one I provided you. They also go into more depth about the various signs and symptoms based on the developmental stage. The risk factors for gastroesophageal reflux disease in the pediatric population is another one that depends on the patient's developmental stage. So cigarette smoking differs in the pediatric population based on if the patient themselves is smoking or if they are exposed to secondhand smoke. Exposure to high-risk foods, so you would see this more in our older patients because we're not going to give our infants and young children things like spicy food and chocolate, maybe some young children, but not our infants. Diabetes can be a risk factor because it does prolong the gastric emptying time. Obesity is a risk factor that we're seeing contributing more and more to our pediatric population. There is a family history correlation. The neurologic impairment is one we see very often in our pediatric population, the patients with cerebral palsy or developmental delay, or any type of neurologic impairment that causes the motility of their gastrointestinal system to be not in sync or impaired. Chronic lung disease is also associated with GERD, as well as premature birth. There's a few ways to diagnose gastroesophageal reflux disease. Some are more official and thorough than others. There is a thorough history and physical can sometimes be enough, but in our younger patients, it's really important to rule out more serious conditions. As I said earlier, the infants that present with the apparent life-threatening event are the patients that we wouldn't just take a brief history and physical and say they had GERD. We would rule out seizure disorders or other things that could have caused that event. Esophageal pH monitoring is one of the things that we can do to further investigate whether the patient really does have GERD. What this is we just put a scope down the esophagus and it's got a little pH probe at the bottom and it detects how long the esophageal pH is less than 4. So it gives that in a percentage of time, and that we call the reflux index. So that's what the RI is, it's reflux index. We can also do a combined multiple intralumen impedance and pH monitoring, and that basically just measures the movement of fluid, solids, and air into the esophagus as well as the pH. So it gives a more overall better picture about what's actually going on in the stomach and esophagus and what's causing the changes in the pH. We can also do the esophageal manometry, and this helps us determine whether the patient might need a prokinetic agent. It's not diagnostic of GERD, but it does help if you know that a patient has a lower pH in the esophagus. This can determine that one of the reasons might be impaired kinetic activity. Endoscopy is also a good thing to do if you think that there might be Barrett's esophagus present. It's the only way to diagnose Barrett's esophagus because you're actually looking at the esophageal tissue. Another unfavorable way to diagnose GERD is to just try an empiric trial of acid suppression. There's really no data in pediatrics that says this is okay. There's only scarce data in adults, and it's just basing your history and physical, assuming that they have GERD but not doing any studies. And unfortunately, it's led to large overprescribing, overuse of acid-suppressing agents. Moving on to the treatment of gastroesophageal reflux disease, so after a physician has made a diagnosis, what do we do for these patients? Lifestyle interventions are really important, especially for our younger populations, the infants that are only formula fed. There might be things we can do to the formula, time of eating, or positioning that could avoid the use of medications. In our older patients, teenagers, we would recommend weight loss if they're morbidly obese. It's difficult to recommend weight loss in young children because we don't want to inhibit their growth or impair their nutrition. We would advise them to avoid food triggers, so to identify those foods like chocolate or caffeine that are causing their more severe symptoms. Advising smaller meals is also a good idea, and in our young infants that are only on formula feeding, we can increase the caloric content of their formula, so we can add little packets of calorie fortifiers to their formula, and it allows the formula to be the same volume but a higher calorie content. Postprandial positioning is also a way that you can decrease your symptoms of gastroesophageal reflux disease. It's actually found that placing an infant in a car seat position can exacerbate their reflux. Laying them on their belly is actually the best position. However, it's not recommended for children less than 1 year of age because of the risk of sudden infant death syndrome. So even if a patient has reflux, we would still recommend back to bed for the patients that are less than 1 year of age because of the risk of SIDS, or sudden infant death syndrome. We can advise our older children and adolescents that have the ability to sit up on their own to remain upright after a meal, and then if they do lay down, to lay on their right side. And if you think about it, it's basically just our anatomy that makes laying on the right side better than the left. Your stomach is a little bit higher on the left side where it attaches to the esophagus, and then it drops down on the right side where it attaches into the duodenum. So if we lay on our right side, it allows the gastric contents to be emptied a little bit sooner and easier with the flow of gravity. So we can also change an infant's formula to decrease their symptoms of gastroesophageal reflux disease. We can eliminate cow milk protein, and for those infants that are exclusively breastfed, this means that mom has to eliminate cow milk protein from her diet, and this has reduced a lot of gastrointestinal symptoms, GERD being just one of them. We can thicken their feeds to make it a little bit more difficult for the gastric contents to get up into the esophagus. They actually provide an anti-regurgitation formula on the market now, and it's a pre-thickened formula. You might have to get if the baby's bottle fed, you might have to get a thicker nipple with a bigger hole so that the formula can get out of it without the infant having to work really hard to eat. It's not superior than just thickening your own formula with rice cereal, but it is a lot more convenient to buy it pre-thickened. If the lifestyle interventions aren't enough, or if they failed it, or if they're non-compliant, we can recommend pharmacologic therapy. So we'll talk about 4 different classes of agents, and then we'll finish a lecture with surgical options in severe cases. The first class of medications we'll talk about are the buffering agents. These are commonly known to, in layman's term, as antacids. They're only really recommended for on-demand usage of immediate symptom relief. They're not intended for chronic regular use or for patients that have erosive esophagitis. They only temporarily decrease the acidity of the stomach, so they don't promote any type of esophageal healing or decrease the release of acid. We want to be cautious with the aluminum-containing antacids because of the risk of aluminum toxicity in our infants and the potential adverse and serious outcomes that can occur from aluminum toxicity. Also caution about calcium-containing antacids and their overuse. So these are not agents that we would recommend around the clock for long-term use in patients with gastroesophageal reflux disease. These are the agents we'll talk about, and just as an FYI, Mylanta is another product that's out there. It's a combination of aluminum hydroxide and magnesium hydroxide. So the first one, aluminum hydroxide, and all of these buffering agents, they work by neutralizing the gastric pH, just temporarily. So the MOA will be basically overall the same, they just do it a little, the end result is the same, but they all do it a little bit different. Really, the biggest concern with this one is the aluminum toxicity. A good counseling point for parents is that it can result in white speckled feces, so that's something that might cause an alarm, especially for the new parents. Calcium carbonate is a very popular on-demand antacid that's used. We do have an oral suspension and lots of different flavored chewable tablets that children like. This one, it's important to note that the dosing is based on calcium carbonate and not elemental calcium. So if a patient's on 500 milligrams twice a day of calcium carbonate, they're actually getting less elemental calcium. So that's a calculation that's important to know for clinical practice. Magnesium hydroxide is the last antacid we'll talk about. With this one, there's lots of different magnesium salts available on the market, but the hydroxide is what we use for the antacid effect because of the way that it neutralizes the gastric pH. So the adverse effect with this one that is most unfavorable in our pediatric population is the parageusia, or the bad taste in mouth, and it can also very easily promote diarrhea. So it's not usually our first agent of choice for antacid because of those adverse effects. The next class of agents are the surface protecting agents. These make a physical barrier on the upper GI tract to actually separate our body from the acid. So it protects our stomach and our lower esophagus from actually becoming in contact with our gastric acidic contents. It's not recommended as monotherapy for erosive esophagitis because we're also going to want something that's going to stop the acid production in erosive esophagitis. We do use it in combination with acid-suppressing agents. And then we also use this to help treat gastric ulcers and esophageal ulcers because it does promote healing. Really, the only one that we really use is sucralfate, and this medication, it's very difficult when we have patients on multiple other medications because they can take it up to 4 times a day or every 6 hours, and it really inhibits the absorption of other medications. So trying to time this medication every 6 hours plus all the patient's other home medication can turn into pretty much a nightmare. So we at least want to separate this medication by an hour with other meds and meals, but really we just do the best we can in clinical practice. So this is a large room for error when we get this medication as a new start when a patient's in the hospital. Just by timing the medication can cause a lot of drug interactions. We have 2 different classes of acid-suppressing agents, and I'm sure you learned about these in your adult lectures on gastroesophageal reflux disease. We use pretty much all the same medications minus a few PPIs we don't really use in pediatrics. The H2RAs are histamine 2 receptor antagonists. They work much quicker than the PPIs do, but they don't cause complete acid suppression. So if you can see on this picture down here, that's a parietal cell, so those are the cells that line our stomach. You can see that big red X is through the histamine receptor because when histamine binds to that receptor on the parietal cell, it stimulates the proton pump to release a hydrogen ion into the stomach or release acid. So by blocking histamine, we are still allowing the acetylcholine and the gastrin to be able to stimulate the proton pump. So it's not a complete acid block, but it does definitely increase the pH of our stomach. There are some class adverse effects that are important to note. Just all H2RAs have been associated with the increased risk of acute gastroenteritis and pneumonia, especially in pediatric patients, and we think that might just be due to the fact of the higher pH in the stomach. These have all been pretty strongly correlated, except ranitidine is the most weakly correlated for some reason. We really avoid the use of H2RAs in neonates because of the increased risk in mortality, necrotizing enterocolitis, which is NEC, and infections in neonates. So it takes a lot for us to start a medication like this on a neonate. We don't throw it on as easily as we do in some older patients. Altered mental status is a side effect that is more strongly associated with the H2RAs because they do cross into the blood-brain barrier, especially ranitidine does. And this one can be hard to determine in our pediatric population based on the developmental stage and then also some of the developmental delay or mental disorders that we see in our pediatric population. Vitamin B12 deficiency can develop with chronic long-term use, and then H2RAs as well as PPIs will have absorption interaction because of the higher pH in the stomach. These are the 4 H2RAs that are on the market, and we will use all 4 in the pediatric population. However, cimetidine is the most unfavorable. This one is definitely not first line. We very rarely see it used in pediatrics anymore because of the association with adverse effects and the extensive drug interactions. It's really the adverse effects that we've seen that are the most alarming are the hepatic impairment, the pancreatitis, and the gynecomastia, as well as the aplastic anemia. So lots of severe side effects, lots of drug interactions really put this one out of use. Famotidine is one that we see pretty commonly. If you notice, infants, dosing is once daily, and then older children, 3 months and older, we use it twice a day, and that's because infants tend to clear it a little bit slower, so they only need once daily administration. Also, a side effect of famotidine that I feel like is overlooked sometimes is the potential for it to prolong the QTC. So that's just something to keep in the back of your mind for this medication that we kind of see overused in our patient population. Nizatidine is another one. It's not as popular as famotidine and ranitidine, maybe because of cost purposes, but it does still have some drug interactions and side effects. But one of the interesting things that I found while preparing this lecture was I found some studies that looked at mixing the oral capsule with various other juices to administer to pediatric patients. And they found that it was okay to administer with V8 juice, Gatorade, cran grape juice, but it was not okay to mix with apple juice. For some reason, mixing with apple juice reduced the bioavailability. It's not due to acidity, since the cran grape is also very acidic, so I'm not really sure what it is about the apples that decrease the bioavailability. Ranitidine is the last H2RA that we'll talk about, and if you'll notice the neonate dosing versus infants and older kids, neonates actually clear it faster, so their dosing is Q8 hours. This one is the most notorious for having the confusion, agitation, or altered mental status changes, but it is available in an oral syrup that's pretty sugary and tastes pretty good, so we do see it used pretty often. Proton pump inhibitors is the second class of acid-suppressing agents. Oh, I forgot to say one thing that's very important about the H2RAs, and that is the tachyphylaxis. So with long-term use of H2RAs, you can definitely get tachyphylaxis, which is a decreased response over time. So since we're constantly blocking the histamine receptors with these medications, we can have upregulation of the acetylcholine and the gastrin to bypass the histamine blockade. So it is common for us to see a patient no longer have a response to this medication after they're on it for a while. Okay, back to the PPIs. Proton pump inhibitors are different than H2RAs because they cause complete acid block. They have an irreversible bond to the proton pump that causes 24 hours of complete acid block. So in this picture, you can see that the proton pump, which is that yellow little X in the parietal cell, is what is blocked in this picture you'll see omeprazole because I got it from the omeprazole website, but it irreversibly bonds to that proton pump. So no matter how much histamine, acetylcholine, or gastrin is trying to stimulate this parietal cell, we will not have any acid production. They do have a delayed onset, however, because they have to get to the parietal cell basically through the back way. So when we take omeprazole or any PPI, it has to get through the stomach, so that's why they're all enteric coated or delayed release, and then it gets absorbed through the intestines, enters our bloodstream, and then gets to the parietal cell through the bloodstream. So they do have a delayed onset of action, and it does take the parietal cell to die in order for the drug effect to wear off. The class effects of the PPIs, if you do get diarrhea, constipation, headache, or nausea, you can try to switch to a different PPI and see if that side effect goes away. It does cause drug-induced hypergastrinemia, which can eventually turn into carcinoid tumors, so that's definitely something to look out for with prolonged chronic use. There's also drug-induced hypochlorhydria, which we think is what correlates PPI use to things like pneumonia and gastroenteritis, as well as necrotizing enterocolitis. We think this helps, this is one of the causes for an alteration in the gastric flora. Some class drug interactions, these are the ones that most severely have absorption interaction as opposed to all the other medications we've talked about in this lecture, and it's because of their complete acid block. So iron supplements especially are difficult to have absorbed for patients that are on PPIs because of the 24-hour acid block. They're pretty much all metabolized by CYP enzymes, so we'll have those interactions as well. And then vitamin B12 deficiency can develop as well, just like same with our H2RAs. I also talk about the administration on this slide and how it's important to keep the enteric coating intact. That way the medication can bypass the stomach. You will see advertised an immediate release omeprazole. That just, it's kind of an advertising ploy. The omeprazole still has to get to the intestines to be absorbed and then still has to enter the bloodstream in order to be effective. Basically, it just doesn't have the enteric coating. They just mix it with sodium bicarb to increase the stomach pH, and that way it can make it through the stomach. So this isn't studied in children, so we don't tend to use it, the manufactured one that's on the market, but just FYI. This is a list of the proton pump inhibitors that are on the market, but the ones with the asterisks are the ones that we use in the pediatric population. They have studies and dosing. Esomeprazole, which is the S isomer of omeprazole, is used a lot in our pediatric population. It's got the convenient dosage form of the packet, and this goes very well with our patients that are G-tube dependent. It doesn't clog the G-tube, which is really nice. A lot of patients that are G-tube dependent have issues with that. And then it's also got various CYP interactions. Lansoprazole is another one that we see pretty commonly. It has a dispersible tablet, and it's important to let the patients know that they can't chew this or crush it because that will be breaking through the enteric coating. So just because it's dispersible doesn't mean you can chew it. And all of these dosage forms are compatible with feeding tubes. Omeprazole is another one that we see commonly in our pediatric population. It's got a delayed release capsule, a packet, and then you can also compound an oral suspension. They do have compounding kits available that make a more palatable suspension, and that's pretty favorable in our pediatric population. Just an interesting fact about omeprazole is that it might be more bioavailable in our patients of Asian descent, so they might be able to get away with a little bit smaller dose than some of our other patients of different ethnicities. Pantoprazole is, I believe, the last one. Yes, the last PPI that we will talk about. If you notice the dosing on pantoprazole, it's pretty similar to all of the PPIs, and actually just a little hint to dose PPIs on the fly. They're all right around 1 milligram per kilogram per day. They do give a dosing range, but if you just have to guess and you spit out 1 mg per kg per day, you'll pretty much be right. You might underdose the pantoprazole dose a little bit, but all the other ones you'll be spot on. This one, pantoprazole, has packets that are appropriate for feeding tube administration. There is an oral solution recipe that you can compound from the tablets, but it's extremely cumbersome. Like, the first step to make this suspension is to wipe off the imprint of Protonix on each tablet with ethanol and then to let them air dry. So just that first step there would probably take you like an hour. And then after you crush it and mix it, you have to stir for 20 minutes straight. So I don't know what pharmacy has techs that would be able to have time to compound this pantoprazole solution. So I don't know how often that's actually used in clinical practice when you can just use the packets. The last group of medications we'll talk about in this lecture are the prokinetic agents. They're really only for patients that have a proven impaired motility of their gastrointestinal system. So this isn't going to have any effect on our acid suppression, but it can reduce our reflux index just by moving the contents along out of the stomach, so giving them less chance to actually retrograde back up into the esophagus. GERD is actually an off-label use for most of these medications, and throughout this pediatric elective, you will see a lot of off-label usage. So it is best to administer these medications before meals. That way you can give the drug time to absorb and get working before the patient puts food in their stomach. We'll talk about 3 different agents today, and they all have 3 different unique mechanisms of action. Cisapride is an old drug that's really fallen out of favor. In post-marketing studies, they found increased risk of sudden death. Finally, they correlated that to a QTc prolongation. So this medication frightened a lot of parents. It's really unfavorable. You can only get it through the manufacturer. It takes a long time, and the patient has to meet specific criteria and go through lots of testing. So it's definitely one that we would avoid in patients with underlying cardiac arrhythmias. Erythromycin, as you know, is actually an antibiotic, but one thing that it also does is stimulate motilin. Motilin is a natural hormone that stimulates our gastrointestinal motility, and it can actually help increase the lower esophageal sphincter pressure. So this is definitely an effective medication in our patients with gastroesophageal reflux disease that need some help moving things along. We use the erythromycin ethyl succinate formulation for GERD, so there's different salts of erythromycin available. This one can also cause QTc prolongation. It's got other drug interactions associated with the CYP enzymes, and it can also cause some hepatic impairment, so definitely not a benign drug. Metoclopramide is also not a benign drug. This one also works on our dopaminergic receptors, so with prolonged, regular, around-the-clock usage, we can see lots of dopamine-related side effects. This is extremely detrimental, especially to our patients that already have underlying neurologic disorders or developmental delay. We might not be helping them out by putting them on scheduled metoclopramide, but it can be very useful PRN, and especially if one of their main symptoms of gastroesophageal reflux disease is vomiting or excessive regurgitation, it can help with that. Finally, we will finish up with surgical options. That was all the medications that we use in the pediatric population. So if they fail all lifestyle interventions, all medications, they're still having severe gastroesophageal reflux disease that you're worried might turn into Barrett's esophagus. It's causing aspiration pneumonia, multiple hospital admissions, then a physician might recommend a Nissen fundoplication. So that's what this picture is here on the bottom right-hand corner. It's basically where they just take the top little portion of the stomach and they wrap it around and then they staple it. So it just gives the stomach contents less places to go to reflux back up, and it also helps them drop down to the bottom of the stomach from the esophagus. It does not have anything to do with the gastric emptying time, so if that's an issue, it won't be solved by this procedure, and it doesn't help with any underlying esophageal clearance either. If that doesn't work, a total esophagastric dissociation is another extreme option, and it's exactly what it sounds. You disconnect the esophagus from the stomach, and then the patient is then G-tube dependent and can't take anything by mouth. So that's obviously a very last line option in some of are more severely disabled or severe GERD patients. And these are the references that I helped use. Please look at those other 2 supplemental readings that I gave to Dr. Solomon, and let me know if you guys have any questions. Thank you.